So you've been diagnosed with obstructive sleep apnea, and you've seen your primary care doctor and a sleep medicine doctor, such as pulmonary doctor or a neurologist, or in some cases an ENT, and you've been given what is the standard frontline treatment, the gold standard, which is CPAP, continuous positive airway pressure. 65% of people can tolerate CPAP. So there's another 35% who can't. And there's nothing to be concerned about or worried about if you're not able to tolerate it. There are just some people who can't. We compare it to an air blower strapped to your face, right? So it does work. What it does is it blows air through your nose and mouth to push the tongue forward so there's room for air to get down into the lungs. Because sleep apnea is often the tongue falling back at night, blocking the airway, causing this turbulent airflow and causing you to stop breathing. For people who can't tolerate CPAP, and you've tried all these different types of masks on the nose, in the nose, around the whole face, and you rip it off at night and just wake up still feeling bad, or you're able to wear it for a few hours, but then just wake up with it on the floor. It's not something to be ashamed of. It's something where you've done your best, you've tried what the doctors have asked you to do, and you're just not able to tolerate it. For many people, you may have also tried an oral appliance, which is great for mild to moderate sleep apnea, but doesn't work for people with severe sleep apnea. So what are our other options? Surgically, things that used to be done, we used to take off part of the soft palate and the tonsils, which you may know people have had that done. In some patients, it's effective, but often this is usually caused by the base of tongue falling back, and that doesn't address it when you just operate on the soft palate. Plus, it's a 2-week recovery, and it's not very fun to go through. And you may know people who have had called a UPPP or uvulopalatopharyngoplasty, and they were down for 2 weeks. It was a rough recovery, and they didn't see a lot of improvement. Well, we've gone away from that in a lot of situations, and for the right patient who meets the criteria, there's a new procedure that's called a hypoglossal nerve stimulator implantation, which is also in some cases known as the Inspire procedure. That's one of the devices that we use. That's something that I do. What that is a device that stimulates the nerve that moves the tongue, which is the hypoglossal nerve, so that when you breathe in at night, it pushes the tongue forward and creates room behind the tongue for air to flow through. And it goes in the rhythm of your breathing. And it's very effective. 80% of people who get this surgery done will drop their events per hour to under 20 and by half, which again, it may not be a home run, but we're getting a triple out of this and you're feeling a lot better, especially if you're someone who had 50, 60, or 70 events per hour. And the criteria for this have gotten a lot bigger, meaning that now you can have up to 100 events per hour and a body mass index up to 40 to get treated. Sleep apnea is something that causes a lot of significant risks and issues with your life. Not only you're tired all the time, you can't think straight, you never get good rest, but it really increases your risk of heart attacks and strokes, especially if you have severe sleep apnea, which is over 30 events per hour. So who qualifies for a hypoglossal nerve stimulator implantation, and what's the procedure like? Well, for patients that have tried CPAP and can't tolerate it, and this means you've tried different masks, you rip it off at night, you just can't wear it. It's not necessarily for people that aren't happy with CPAP and that they have to wear it and they don't like to travel with it. The reason is that if you can wear CPAP all night long and it treats you, it works. Probably more effective than anything else out there. And surgery has risks. Most people, this is a very low risk surgery compared to something like I talked about before with the removing part of the soft palate. There are a few times that complications happen, and we don't want you to go through this unless we absolutely know that it's going to make a difference and it's, what we would say, the juice is worth the squeeze, right? So the surgery involves making an incision in the neck and in the chest, usually on the right side, because at some point in your life, if you need a pacemaker, it goes on the left. So we put this implant on the right. It's a small pacemaker-like battery that's implanted over the pectoralis muscle in the chest, a small sensing lead, which this may change soon, between the second and third rib. The new sensing generator and battery may be able to do that on the next generation for Inspire. And then incision in the neck to find the nerve that moves the tongue and put a cuff around the fibers of the nerve that push the tongue forward rather than pull it back. So if you can imagine, when you breathe in, the tongue goes forward. So what are the qualifications for the surgery? Well, you have to have between 15 and 100 events per hour. So moderate to severe sleep apnea. Mild sleep apnea is not a qualification for this. You also have to have a body mass index right now of 40 or less. And you also have to have failed CPAP, like we said before. You also have to have less than 25% what we call central apneas. Now, obstructive sleep apnea is caused by the airway closing up, the tongue falling back and blocking it. A central apnea is where your brain forgets to tell you to breathe and take in a breath. So if you can imagine, if we have a system set up to push the tongue forward when you breathe in, if you forget to breathe, then it's not going to work. So it has to be less than 25% central apneas. And you have to have a sleep study, usually within 2 years, but at least within 5, depending on your insurance. And you have to pass what's called a DISE, a drug-induced sleep endoscopy. Now, this means that we have to recreate what happens when you sleep. So you would go to an endoscopy suite or an operating room and get some IV sedation to put you to sleep for about 5 minutes to make you start snoring so that you're breathing, but you're snoring. And then I would put a small camera with a scope through your nose to look at the soft palate to see how it closes. So we're looking to make sure the soft palate closes more back to front than in a circle. Because if it closes more than 75% in a circle, then you're not a candidate. And if you can imagine, if the back of the soft palate is the same as what happens behind the tongue, if everything closes in a circle behind the tongue, when the tongue tries to get pushed forward, it's all closed back there so that no air can get through. So it's not going to be useful for you. Now, 90% of people will pass this scope. But if you don't, there are other procedures, something called a lateral wall pharyngoplasty that can be done to open things up so you can then pass the DISE. Once you have passed the DISE and you've met the other criteria, then we submit to your insurance and go forward with the surgery. The surgery is actually very well tolerated and the recovery is much less than all these other sleep surgeries you may have heard about in the past. So the incisions are small. They usually heal up very well. People go home the same day and they usually can get taken care of with something like Tylenol alternated with Motrin for pain, maybe a limited narcotic if they need it. And you're back to normal activities within 2 to 3 days and strenuous activities within 2 weeks. But mostly it's sore and there's some swelling. Risks with this that we worry about, which are much less than 1%, are very rare. Injury to the nerve that moves the tongue is very rare. Some people have some trouble moving it for a week or two very minimally afterward, but not enough that they usually notice very much. There is a nerve that moves the corner of the lip that's in the field of where we operate. It's very rare to have that injured. You might have some trouble eating or talking if that got injured, but again, that's exceedingly rare. Bleeding and infection is rare. Failure of the implant is rare, meaning something breaks on it. And then putting a hole in the lung, again, very rare. And we always get a chest x-ray afterward just to make sure that's normal. Once you get home and everything is going well, I'll see you a week later to make sure your incision is healed up. And then 6 weeks, sometimes at 4, sometimes at 8, depending on how the nerve heals, you will then get your implant activated, which you go see usually a sleep medicine doctor to turn on the implant. And when they activate it, they give you just enough electrical stimulation that the tongue moves. That's level 1. And then you have your remote that you turn on the device at night and you start at level 1. And every week you increase that by another level till you get to 10 or you start feeling a lot better. The best part about the implant is that with the remote, you just put it over your chest, hit a button, and there's a delay of 30 minutes, but you can change that the device will kick in so you can go to sleep. And when you wake up in the morning, it usually turns off within 8 hours. But again, you can set that or you can turn it off yourself. Now, if you wake up during the middle of the night and you go to the bathroom, you can hit a pause for 15 minutes or go about your business and then come back to bed. Just know that when you try to talk, your tongue will move with that because you're breathing. So the whole point of this is the tongue moves forward, air gets through and opens the airway. And so you start feeling a lot better. About 3 months after having the activation, you may get a formal sleep study to tweak the settings to where you are set at the best setting that you can be to give you the best results. And then probably see your provider with Inspire probably every 6 months, but usually yearly just to check and make sure things are going well.